We have two Michaels this year, Michael A and Michael S, and we have Dr. Awad as well. So pretty much everybody's the same. So because of sake of time, we're going to jump right to it. Mike, you want to present the case, and then we're going to show the angiogram. Want to map them?
Anybody feeling wobbly in the legs?
Nobody's wobbly. We just we heard your lecture. We loved it. It was awesome. We learned a lot of things.
Move the ultrasound down.
You want to take the balloon and dissect it? In the meantime, he's getting.
And I need more slack.
You know, because this is what these guys came for, right? So Dame, birth tip catheter, and I need a Confianza and a this one. What is it called?
014 Trailblazer.
014, not Trailblazer. I need a
CXI.
Nope, I need a this one. Command. All right, go ahead, Mike.
Is it Confianza?
And everyone, so thanks again for joining us. So we have another case of a DVA. So patient's a 74-year-old gentleman with lifestyle-limiting ischemic rest pain, left greater than right, as well as a non-healing ulcer that we'll show a picture of on the left foot. Rutherford Grade 3, Category 6, and WIFi Stage 4. So despite GDMT and supervised exercise therapy, still having symptoms. Workup included venous mapping without any adequate veins to use.
Let me know.
His past medical history there, you can see hypertension, AFib, type 2 diabetes, ESRD, on dialysis. He has a history of right AK and heart failure with moderately reduced EF. He is a former smoker, and you can see his medication is down there below. He's on good GDMT.
Can we get the ultrasound up?
Ultrasound.
This is a picture of his foot ulcer on the left.
Ultrasound up.
And then we'll show the more updated pictures here in just a second.
So basically, he's got a non-healing ulcer of the foot. So he was, Dr. Guja is taking care of him. And maybe, Karthik, you can tell us about this patient?
So yeah, he was basically
Can't hear him.
So he was basically being taken care of by an outside vascular surgeon in a hospital in Brooklyn. But so they did the AT, they attempted the AT. He has a wound which is not healing. They did the amp of the great toe, but still not healing. And so now the wound is not only just on the great toe and second toe, but on the lateral aspect also of the foot. So now they're talking about transmet. The problem is they don't think the transmet is going to heal either. And he already has and the family also wants to be very aggressive because he pretty much had the same issue on the right side. He had a transmet, then BKA, then AKA. So they don't want to go the same route. So the DVA was attempted outside, but they just, for some technical reasons, they were unable to complete the procedure, or they were unable to get in. So it was sent to me for second opinion as well as a second attempt of the DVA.
So angiographically, guys, as Ajit is, it's going to be, so you can see the ulcer. So the anterior tibial artery is filling. However, the arch is very incomplete. And hold on, let me go one more here. The arch is incomplete, and the posterior tibial artery does not have any flow in it at all. So you can see you have the donor artery. Obviously, you have the AT and the perineal come off. There's no posterior tibial that you can speak of. Osteally, there seems to be something that Ajit and I can see right at that spot, right there on coming off the TPT. We think that's the posterior tibial. And then over here, you can see here that the perineal comes down, peters off distally, and you can see the perineal gives rise to a collateral, which again does not give rise to the posterior tibial. And then you can see in the lateral foot, he moves quite a bit, so I'm going to go to the one that shows. The lateral foot here shows that the PT comes down, but again, no flow into the posterior tibial artery or into the plantar surface of the foot. I'll take another view in a second just to let you see another view. But in the meantime, that's what, Stephen, we're planning on doing is accessing the lateral plantar artery here. Excuse me, the posterior tibial is the target to do our DVA.
Dr. I think it's
You
a
want
great
the small needle or the big needle?
Big one.
I think the dorsalis pilates is included, and what you have is a tarsal feeding the foot. The AT is a dominant vessel.
There you go.
Perineal is not going anywhere, but you have a blind PT occlusion. So I think the procedure adds blood to the venous concept and brings additional blood. So what you have to look out for in this case is make sure that you're not shunting too high and not stealing from
a great flow.
Dominant AT. So I would suggest maybe 4 centimeters south of the DP trunk.
Yeah, but we're gonna have to tunnel we're gonna have to tunnel into the PT. So I'm trying to get a flow here. I'm not able to get any injection here.
You want to go up?
We're gonna go up and see what's going on here. Oh, it looks like, yeah, looks like there's either the sheath is occlusive or there seems to be no flow.
Yeah, sheet's probably occlusive.
The sheath's probably
Do we get
occlusive, so I'm
heparin
gonna
yet?
pull the sheath back.
Yeah, we just gave 10,000 heparin.
So I'm just gonna pull the sheath.
PK, is there a role to use a short sheet? Maybe that will help, will instead of a long sheet.
What happened here?
There's very poor flow all of a sudden.
Yeah.
Very, very poor flow.
One
Interesting.
second.
We give 10,000 of heparin.
Give me some nitro.
Look at that. We didn't put anything. We haven't put anything in this body. It looks like all clot. Wow, gets more interesting.
Is the blood pressure okay?
Blood pressure is fine. Waveforms are fine, but I don't know what's going on. Give some nitro, guys.
Yeah, that's what I'm doing.
We're gonna give some nitro and take a picture. But anyway, so in the meantime, we're
Get
gonna
an
get
ACT.
access here.
Oh, the tourniquet's up.
Tourniquet's up. Ah, so
That's
sorry.
what it
I guess they must have put it
Drop
up
the
pretty high.
tourniquet, guys. Drop the tournament.
Doctor,
What's the tourniquet set to?
Dr. Rao decided to put the tourniquet out and not inform anybody in the room. That's
Well,
interesting.
I didn't think they put the tourniquets at 300.
Killing you, PK.
Huh?
Well, it's
You can give 100 of Neo.
Ajit loves to do this to me because he knows I get all paranoid. He laughs at me. I told you he laughs at me because I get all paranoid about these things, and he's like, let's see. Oh yeah,
yeah.
look at that. All right, the flow's there.
better.
Okay, fine. All right. In the meantime, we're gonna go ahead and map this artery, and then what I'm gonna do is I'm gonna go above, and I'm gonna try to get into the posterior tibial while Ajit shows you the anatomy below.
Alright.
You want a mic?
So this anatomy,
1.4 or a balloon? ACT.
oh yeah, we gotta put the cuff up for this part
Yep.
though.
Put the cuff up, guys.
Yeah.
All right, so we're gonna show you the now you're gonna look at the lateral plantar. That's not it. It's a tourniquet.
Can we
Yeah,
put
I know.
the?
I
Can you guys
realized
see
that.
the ultrasound?
Yeah, we do.
Okay. So tourniquet's up, following the. So starting distally. Get more gel here.
So Ajit, you're right now trying to get into the lateral plantar.
Yeah. So I'm starting.
Decrease
This
the
is
depth.
by the ankle here,
You want to decrease the depth?
and then I'm following it kind of as far down as I can.
So to
Yeah. Give me a
annulate
sec,
the
please.
lateral plantar, you start from the behind the
It's actually
medial
more, I
malleolus,
think.
then track your way down.
Yep.
Yeah.
So now you got to find the bifurcation basket of the medial and lateral, and then follow the lateral. And then as I was telling
I
you
think
guys,
that's
you
the bifurcation there. Or no.
No,
got to go further.
Can we increase
that's
the
your
depth?
bifurcation, right? That's why I'm
That's
saying.
your bifurcation.
That's what I was saying. Like
Increase
decrease
the
the
depth.
decrease the depth.
The gain.
Yeah, the gain is too
A
much,
little more.
guys.
A little more.
Increase the depth, and then you gotta. I don't know. Increase the gain.
I got you.
Hold on, we're gonna change our thing here.
I got you.
Use the other probe. Maybe the other probe will give you a better penetration. Not the
Yeah.
hockey stick, 'cause that's-
Yeah, I think.
sometimes, these dialysis patients can have quite a lot of edema in the foot.
Can you guys see it? We can see it well in here.
Now we can see better.
That's the medium.
There it is. You see, that's a lateral right there. It's
That's a lateral right there.
You see it now?
I saw it earlier on.
Yeah. Okay.
Is that under the foot? or-
Right there.
That's
Yeah,
under the foot.
that's a good view. I think we'll go right there.
Yeah.
But are you fine? So the key here is to get distal enough
I think.
because you want that's it right there. You see it
Yeah,
now,
that's where
guys?
it branches.
So then it bifurcates.
That's it. That-
This is better, right, Ajit?
Okay, yeah. So this is important. Can you guys take the camera and show where Dr. Rao's hand is on the foot, so that they can see? Can you show the camera, please, AV team?
Yeah,
Can
my
you
left
show the
hand.
camera- yeah, to the left hand on the foot.
I'm close to the metatarsal heads.
That's
not
exactly
quite there.
it. Metatarsal head.
But, yeah, close to it.
You see how distal we are? I mean, we try to go as distal as we can out to bypass the valves. So let's see here. We'll get access here.
Okay, good. And both are compressible. Lidocaine.
Same location.
So we're going to give some numbing medicine, and I'm going to hold his foot.
Calcium is in between. There's a Mickey Mouse. 2 veins and then the calcified arteries.
So can I get a vert tip from above, guys? So once Ajit gets in, I'm going to use his wire in the vein to be able to tell me where that posterior tibial ostium is, and then we'll just tunnel through it and we'll just get in.
Thick skin. Can we?
What do you want me to do? Tell me.
I was gonna say decrease the gain, but it's okay. Decrease the gain
Just
a
go
tiny
down on the
bit.
2D.
Yeah,
Yeah,
there we
that's
go.
good.
What's it right there? Is the blood coming out? I can't see.
No, no, no. It's
No,
he
yeah,
didn't. He
I'm
didn't
kind
enter
of on
it
the
yet.
top. I'm just trying to get my angle a little better.
That's better, no?
I think so.
A little bit more.
No blood.
I think you're on the side there.
That's better.
Put your needle on it.
Probably on the side a little bit.
Yeah,
You're on the
it's
side,
on
yeah.
The other way.
Sorry, it's a little
Okay.
awkward.
You want me to hold it for you?
You got some blood back.
No, no, no.
No?
We are far away from the vein.
Yeah.
Well, there's blood in the needle.
Yeah, but I'm not in the right one. There we go.
Yeah,
There
that's
you
better.
are.
That's better.
Okay.
Yeah, you got it. You got it. You got it. You got it. Ajit.
All right.
A little bit more. Pull back.
No, I think I'm too deep. There we go.
Right there. That's it.
All right.
Got
So
it.
now we're going to put the wire up, and we're going to allow this, guys, because especially when you're tunneling. All right, go. So you see how far down we're, Al?
Yeah.
Yep. So this is as low as we can. We want to get as low as we can go. There you go. Now you're going to push this up.
Can you guys show us the fluoro?
Can you show the fluoro, please? I'm sorry. I thought you saw the fluoro. There it is.
Getting
Gotta
stuck.
be, can't be a valve.
Getting stuck on something there.
All right.
You want
let's
to try
let's put the dilator in.
put the inner dilator in,
It's
and then you
definitely
see.
in the vein.
I got to be in the vein. I mean, that goes pretty easy up until that point.
Yep.
Can I have a micropuncture?
There you go.
Just the inner dilator of a micropuncture.
Yeah, I'm going to.
And then maybe a command wire.
Yeah, right here.
Can I have a micropuncture sheet, please? Micropuncture?
All right, vert tip catheter for me up top, guys. So Mikey, pass me the vert tip, or Dave. All right, so in the meantime, I'm going to go up top. You can drop your, actually, we're going to take a picture of the feet,
Just
of
the
the
inner.
veins. I'm going to just step on fluoro.
You want some dye? Give some dye.
Dye, well, you have the tourniquet up. Well,
Let's
give
go.
dye through this.
Yeah, I'm getting blood back,
Yeah,
so
that's
let's
what I'm
get some
saying.
dye.
Give some dye through this. Give him some dye,
Contrast.
guys.
We have small. 1 second. Where is the contrast? There you go.
But it's probably a bend. Okay, DSA.
Yeah,
you're
it's just
good.
a little bend. So
There
I
you
think
go.
just
take a command wire.
yeah, command
Command
wire will
wire.
do it.
Command wire will help you.
So just any tips with regards to venous access using angiocath, where you go through and then you pull the stylet out and advance the cannula, or is it all micropuncture based? Is that what you guys advise?
We always do
Yeah.
micropuncture.
Always
here.
anterior is better.
Yeah, I
So,
think
you
the
know,
less manipulation, the
Less
better.
manipulation is better.
What was it, Karthik?
Anterior axis is better. You don't want to go through and through, pull back and everything.
Just have
Because
a
once you,
shape to it.
yeah, because you create a lot of posterior trauma to the vessel. So especially when you start the DVA process, and once you have the DVA, you might have a lot of extravasation. So because you're going to put a 4-5 slender. So
Can I get
usually
a different
anterior
shape to
puncture
this?
is, yeah, I got it.
Different shape to that?
Give me a fielder wire, please.
No, don't go with the fielder. Go with the
That's okay.
command. Just give us a different shape to the
Yeah.
command.
I already made a bend. Try this.
Alright.
You want to do
Maybe
full bend?
Ajit, if you could flush the contrast out with saline, will help you. So you can't see the wire with saline.
Try, I gave a second to bend. Right.
Here you go, guys. The flush.
Okay.
When you flush, you do a roadmap. 1 second.
No, this is a flush. This
No, I'm saying
this
it
is
will give
saline.
you it'll give you a nice roadmap. So.
Yeah.
It's easy.
Yeah, I think a command is better than a fielder in this case. I think the command is a fantastic wire for these procedures.
So it's more floppy and malleable than
No,
the
you made a
fielder
bend
PT.
already in the
It's
went
just,
back
I
into
just
the
think the
vein.
fielder tip is so,
Pull back.
what's the word?
I don't think I'm through.
Unforgiving. What happened?
No.
The other thing we could try is straightening out the
Ankle.
ankle.
There you go.
Is that through?
There you go. That's it. Push. That's it.
Yeah.
There you go. Nice job. All right. We'll have to do a venogram once we get a sheet in.
Okay, good.
Nicely done.
So now let's put an 018 Trailblazer through this, guys, and change out for a V18. Get a Trailblazer, please, for us.
You want to put a sheath over this?
No, it's not very. Is this
it's
a
a-
stiff one or no?
No, but it's a
No.
it's
Put the Trailblazer. Put a Trailblazer. 018 Trailblazer, guys.
a-
So
So-
Stephen, what
it's a
we're doing
glide
is,
sheet.
I don't want to
Okay,
go with the
go easy.
dilator. Don't, because you're going to kink the wire. Please don't go with the dilator.
No. We're putting the.
Yeah, but go with an 018 Trailblazer first, and then change out for a stiff wire. So the last thing you want to do is bend this wire. When you bend this wire, what's going to happen is you're going to lose access, and you're going to create a problem. So this is when you got to be a little careful. Put a Trailblazer in. Be disciplined. Go with a V18 wire, and then change out for your 4-5 slender. Otherwise, I've done it, and
This is
I've
018?
done it. We've kinked the wire, and then you're sitting there again because now your veins in spasm and all this nonsense. So better to go with the 018 Trailblazer,
Go for it.
and then
So you don't have a sheath there?
Nope, just go
Not
shitless
yet.
with an
No.
018 Trailblazer.
Bareback.
Not yet.
See, there's the Trailblazer going up. So once the Trailblazer goes all the way up, I'm just going to change out for a stiff wire, which is the V18.
Okay, V18.
So once you get a V18 in there, then you can put any sheet you want, the 4-5 slender, whatever goes right in. So it's just a simple thing. And the other thing also, you don't want to lose this wire because you had such trouble crossing it. So now you also want to put, once you get your V18 in, you can put a 4-French catheter in and change out for a 035 stiff wire. So you can have a stiff wire available for you if you need to. So in the meantime,
PK, if you lose this vessel, you can always go on to AT, right? You've done it before.
I don't want to ever do that again, in my opinion. Oh my God.
Can we open up 2 Grand Slam wires?
So now what we're going to do is I'm going to have to tunnel from above, but I want Ajit to leave this next to the vein, and then we're going to have to find the PT ostium from above. So when Ajit leaves this next to the vein and he can put the sheath in, I'm going to come from above with a
Okay.
sorry.
So PK, you're gonna try and get as far.
I got it.
Once you get into the PT, you're gonna try and get as far down as you can, a third of the way, half of the way. What's the thought here?
You know what? I honestly, Al, I don't know how this thing is going to behave. So what I want to do is just get this catheter down into the PT, and then decide. Oh, that's not it. Can you guys give me a? That is it. Okay. Can you guys give me a little dye in my syringe? So what I'm going to do is puff out as Karthik gets his sheath in, and then be able to tell. This is it, right? This is not dye?
I'm just thinking out loud. Aside from the steel component that we discussed, it seems easier to stent the artery, the long segment, than the vein, the long segment. Am I wrong about that?
I'm sorry, Al, I didn't hear you.
I said, aside from the steel concerns, is it easier to just get lower down on the leg and stent up the artery or versus the vein?
Say it again.
What do you
Yeah.
think, Stephen?
Sorry, the question is,
In terms of where you're accessing it, aside from the steel concerns, it seemed like what
Magnum,
happened,
yeah, everything good?
it's still not clear what happened in the last case. We blew out the vein and it bled and all that. Is it better to enter lower down and just reline the artery versus the vein?
Let's smack up.
um,
Karthik, I think
think
we're going to have to
you'll
perf
see
this.
the posterior circulation.
No, you can dissect it, no,
That's what I'm
PK?
saying.
Yeah, dissect it. That was the plan anyways, right? Dissect it until the mid PT and get into the DVA. Yeah, dissect it there.
You see that one up there? That's just a collateral, right?
Yeah, I think so,
Okay.
100%.
Not a high takeoff.
No, I don't think so.
So what do you guys think? You think it's a high takeoff PT up top, or you think it's where
We
I'm
can
at?
put a wire in and see.
Because you see our wire goes close to it too.
PK, maybe a good idea is to get the bone separated with a.
Yeah, exactly. And just go
deeper
more
projection, then you can see
this
the
way.
calcium with a bag up
that way,
shot.
that way, PK. And you'll see the calcium is right there, you see?
All right, give me a confianza, guys. Yeah, but the problem is he's not a very cooperative patient. He only has one leg, is obviously. So I think we're gonna have to go with a confianza here. Give me a confianza, guys.
But it looks like you're in the stump. It does look.
Yeah, does look like it's a stump, no? Because the
Yeah, you
calcium.
can see it a little
That's
bit.
a calcification. Yeah.
So this is again complicates it a little bit more, having this sort of issue going on.
You could also stick by the ankle, right?
Ankle
the
and
PT
then
and just
PT
go up.
and then
No,
go up
go
and
up and
dissect it.
Chronically occluded.
Yeah.
We'll try this first and then we'll go down there.
I'll just dissect it.
So what do you have, PK, on hand?
Just a Confianza and my Vertip catheter. You can see the calcium, Stephen.
Yep.
Yeah. That's it.
Nope, that's a collateral.
Oh, yeah.
That's a collateral.
Is there possible there's a paired PT?
That's a collateral for sure.
Yeah.
That's your PT.
Little
Maybe it's
diaphragm.
better in the other projection, PK?
That looked good.
Oh, that's collateral.
That's a collateral for sure. Little dicartic.
Yeah.
You want to go lower down the tourniquet? Or?
No, not really.
We could. Should we? Is it still inflated?
You can deflate the tourniquet, guys. Oh, that's right. You got to deflate the tourniquet, don't you?
Yeah. You might able to fill that vessel which we are talking about also much better. To have a better idea.
Okay, inject.
Tourniquet is down?
Percussion, the tourniquet is where?
At the ankle.
I think this is it.
Mm-hmm.
All right, I'm in the PT here. Let's straighten this leg out.
You want me to go RAO,
This is
LAO,
it. This is
LAO
it.
and see?
You can try LAO now. This is it, though.
Watch your legs, speaker.
Yep. Yeah, this is definitely it. Give me a little dye to make sure I'm not in the perineal.
Like a
Looks like I'm in the
peroneal.
perineal.
Yeah, it's a peroneal.
That looked perineal-ish.
That looks perineal.
That better.
Yeah, that was perennial.
That's collateral.
That looks like the PT, PK. That looks like the PT.
No, but
But it's okay. That might be the.
too far out.
Too far out.
But the proximal part might be the PT, no?
Well, I guess the other question: can we just cross where the X is?
Yeah, just cross where the two veins cross.
If we can't find it,
Let's do a DSA. Hold on.
see exactly where that is.
Let's see.
That looks like a PT. You probably went into a collateral there, right there. That's all it is. You can always dissect it and see. Take a 014 like micropuncture and just go with command and dissect it and see where it goes.
Yeah, we could do that.
Yeah.
This is not it, though.
Command will not dissect into a collateral, so it's probably a collateral forming there,
Let me
natural
inject
collateral.
So
Or get a
we can do an
catheter.
ultrasound and then see where we are as
Yeah,
well.
that's a good idea.
Yeah, it's a collateral. See that? That's definitely a collateral.
It's a
So I think we got to come from below with this. Give me that again.
Maybe, PK, how about a cut end of a burr? Maybe that might help to cut the burr a little bit. That might.
Cut the burr?
Yeah.
Cut the. What do you mean by?
Double off the burr catheter because it looks a little bit long and maybe a
Yeah.
more angled burr.
Yeah. Saying is put a smaller catheter.
Yep, we could go with the smaller catheter. This is the PT right here for sure.
You want me to answer?
Nope. Same problem.
So I gotta ask: are we sure it's not a high takeoff?
Yeah, it might be the high takeoff.
Because
Let's go up top.
do you see how the PT vein wire is not close to the
Let's go
popliteal
up
vein?
here. Let's see.
I just want to be
You want me
sure
to take a DSA?
No, we can just cannulate it and take a picture. Give me a little die.
because it just doesn't look like it joins until up there.
You're saying that's it?
I don't know. I don't think so.
Could be.
We can why don't you cannulate it and take a direct shot from there?
Yeah, let's do that.
Okay, give me a little die, guys. Give me a little die. Let me take a shot. Maybe this is the PT.
It's awfully close to the
Looks like.
venous wire.
All right, ready? Makes it more exciting, Dr. Coombe. All for you. Well, we could just do a deviated this vessel, whatever it is.
I think it's a PT. I think it's a high takeoff.
Let me come down a little bit.
It's too.
It seems to be mirroring the PT.
What do you guys think?
Doesn't look like so.
Go a little lower, yeah.
It lives right next to the PT. Who cares, Stephen? Even if it's an unnamed vessel, why don't we just do a DVA off it?
Is it big
Yeah,
enough
the
proximal?
problem
Is that the
is,
question?
if you're gonna put that 7 French device across the joint, and where are you gonna cross?
That is the
That's
PT.
the
That is the
PT.
PT, guys.
100%.
That's the PT.
Behind the knee, so it's a bit tricky, if you're gonna take the inflow off. And, is a 7 French device gonna go through this collateral, the high takeoff of the PT?
So then,
And then
so
you
then
know,
we should.
when you put a stent, if you cross, even if you'll be able to put the 7 French device,
You don't think it's PT?
No, definitely not.
That's so
I'm
big.
not sure, It looks like it, but
So let's
the
do
question
an.
is, will the 7 French device go through this thing on top? And is it enough to drive the DVA?
Wait. You mean to tell me this vessel is not large enough? It looks like it looks larger than a regular PT, no?
I mean, it's
Have a look
fitting.
at the top
It's
end and the joints
so
are
Steve, it's fitting a 5 French
Look, I'll show you
catheter.
now. I'll show you now.
Have a
So
look.
the vessel is at least 3.5.
The origin looks a little snug. I don't know if it's because the catheter was there, though.
You actually have flow across the catheter, so I still don't think that's the PT.
So you don't think there's enough flow in that to drive the PT? So let's do an ultrasound here. Let's stick
Why
down
don't you show
here.
at the level of the foot, where the wire is. It takes the.
Okay, give me a command wire, guys.
Yeah, let's advance wire, see
Give
where
me a
it goes.
command wire.
Right here. It's a, yeah,
Because you can see the calcium of the PT by the ankle,
So we
so.
can just stick below. Let's stick the dissection.
Oh, you want to see if the wire goes into the calcium of the PT, then we'll know.
Yeah,
But no, but regardless, I think
Go
what
for
Stephen is saying makes sense because it's not going to be enough flow to drive the DVA. Is that what you're worried about?
It looks-
Concerned that, yes, atypical location. And how about the perineal? Is the perineal a good?
That's exactly what I was thinking. Maybe we do a perineal DVA.
do from the TP trunk,
Hold on, let me just go. Let me take this down.
I'm giving
Maybe
you.
do it a little bit more distal rather than right in
Go for
the
it. Yeah,
trunk,
take
so you
it.
can keep a couple of collaterals. So I'm not sure how much
Watch your legs.
flow the perineal feeds to the foot. So
But is this really that different than doing a distal DVA if we use this one?
No, but the problem is there's not going to be enough inflow. That's
yeah,
going to
I'm
be the
worried
worry.
about the inflow to drive the thing. So that certainly looks like the PT, huh?
Yeah, it's definitely
Yeah,
the
it
PT.
looks like.
Looks like it's following the path of the vein.
Mm-hmm. Yeah.
And it is bringing flow down to the foot. So
Yeah, that's in the calcium. So that's PT.
That's PT.
That's
It looks
PT.
like I can cross it. So it is the PT, guys. That I'm convinced.
since you're here, why don't you just balloon it? Since it's here, why don't you just balloon it? Because it's a native circulation. It's beating the legs, just in case. So.
All right, give me a 2025. Actually, 3025, 210.
Might not go.
It'll,
You want to take a 2.5?
3025, 210. So Stephen, if we do balloon it and we have good flow in it, why can't we take it? You think even if we shunt it, it's not going to be enough there, even from the proximal? You think because the vein is going to be such a high.
I don't know. Once you balloon it, let's have a look at the flow. If the flow, it looks large on top, because with the catheter on top, I really couldn't see where it comes off the artery. And
Oh, it definitely comes off the artery at the level of the pop.
yeah,
There's no question.
Yeah, let's just look at it again.
Is that a 4 French you have or a 5 French?
It's a 4 French catheter. I just walked it out. It's a 4 French catheter I had in there. So now I'm taking a 3035. Mag up, guys, for me.
So you're okay
Small
doing the
fella.
DVA from the perineal?
I need to see the circulation, how much of the perineal is giving to the foot. So, but
It's not giving a lot to the foot, Stephen.
Yeah, if it's not a lot, then if you are running a DVA from the
Where's the
perineal
balloon?
to the PT,
Right there.
and then you've got a native PT going, then I think you're quite safe to do it. You know what I mean? Because you've got 2 vessels running down the front and the back.
Let me see, 1 second. Sorry.
You want me to give you a balloon so you can balloon it?
Sorry, guys. Okay, let's balloon this. Let's get it open. Go up.
What size is that as a frame of reference? What are you using on that?
3035.
3035.
Down.
So 35 proximally and 30 distally.
Go up here. That was a little dial from above to make sure I'm not coming into the pop.
No, you're not.
Good, perfect. Yeah, it definitely is down. All right, now let's take a DSA.
You want to inject from this itself?
You're such a jerk.
Yeah,
right,
we
ready?
fixed it, right? Flow's good now.
DSA. Okay, pressure. What's going on with my pressure, guys? Yeah, it looks like a pretty robust vessel. Any hematoma or anything going?
No.
Down. All right, let's start a little neo drip here. Inject.
Mm-mm. One second. You inject and I'll hold him.
I mean, it doesn't do much on the foot, so it'd be fine to use for a DVA.
Okay, we're just gonna go ahead and take a shot here once Dr. Guja controls his foot.
Yeah, I got it.
Okay. Well, it definitely comes down, guys. We could probably open this into the foot. But the question is, can we do it as a low DVA or a higher DVA here? Let me just try to go down a little
Probably
bit.
do a lower DVA. No, the vessel is pretty big here.
Let's ask what Steve. So, Stephen, what's your experience here? Walk this out, guys.
I think you've got a lot of real estate. If you do a low DVA, you've got a lot of real estate that's diseased above that you just ballooned. So I would say the DVA roughly at the level of the AT origin,
Okay.
then run that into vein, and then maybe do the DCB.
PT origin.
DCB of the proximal PT since you ballooned and
Ready?
touched it. It was
Actually, we should do not a DCB. We should do line it with DS all the way up. Inject.
It's
think we
just
should-
that it's behind the knee. I'm not sure how that's going to run. You know what I mean?
No, I think it'll be okay, especially in that spot. All right, guys. So let's now let's open the device. Oh,
Yep.
it looks really good.
DVA means what?
So where
We
is
got
it
a
your
DS.
crossing?
Got a DS.
Well, I know, but you're going to do it. We're going to do the DVA here or there?
No, you see the level of the AT.
Yeah,
We'll do
down
the
there.
DVA, and then we're gonna line it.
But-
So
I think
Stephen,
so.
Stephen, the guy has an amputation. You can open. He has an amputation on the other side. He's not a very ambulatory guy. So Ajit and I really aren't worried too much about him getting into any issues with fracture of the DES. So I think what we're gonna do now is we're just gonna go ahead and introduce the what is it called, the snare, and then we'll go ahead and
Not ambulatory. He doesn't
start.
walk at
We need
all.
to switch out for an 014 wire.
Yep, let's switch out for an 014 wire. Okay, now I think the pressure's
crossing
too
around
much.
16.
It's okay.
We need a Grand Slam wire.
What is that?
Crossing around at 16 or something, is it?
I like what Steven said. I want to cross right at the AT
Yeah,
origin.
which is around
Which is
16.
around
That's
16.
where I want to do it.
Roughly. Do the wires look very close to each other, the artery and the vein at the level of the AT?
I'll tell you right now, he is moved. Let me.
Does it make a difference?
Take the
how
roadmap
close you
off.
are to the knee joint?
Yep, they're very close to each other.
Crossing DVA.
They're very close to each
I
other.
don't know, I
They're
haven't
actually on
crossed
top
it
of each other.
Okay.
Yep. Pull that up.
Probably okay.
Change out the wire. All right, give me the.
So,
They look
so
close,
you're going to
okay?
put a
Looks
D.
close.
Are you going to put?
Very
a-
close. You can. I'm gonna
You're going to
sit
put
you.
an Eluvia?
Can you put me on coronary,
Distally,
guys?
maybe, yeah.
Coronary.
You do corner here.
You want to put Eluvia on the top? No, right? Just
look at
regular DES, right?
Well, the regular DS.
Yeah.
Ready?
Hold on.
Yeah, well.
This
Okay, now
feels
walk
like a
this out.
completely off-label educational effort.
Go for it.
Well, I don't think anything we've done today is on label. I mean, last I read, Eluvia is not really on label in the foot.
the vein, especially at the front of the foot.
Okay, and VB and Biobond in the
Where's
foot.
the
I
end
don't
of
know,
this?
guys.
And the
And cutting
BCB
balloon.
of the foot.
And cutting
BCB
balloon.
of the plantar vein.
Wait. Which wire you have?
I have your wire.
Okay, so let's load the crossing device in this wire.
I think the only thing on label today
What do you
was
have?
lunch.
There?
Bottom wire?
Well, listen,
Make
I
a
mean,
series. Have like a series of off-label conferences. I bet you're
That's a
probably
good
better
catch,
attended than most.
Yeah.
all right.
Always assume the worst.
Already great. Go for it. I have it.
I think the high takeoff is a good thing.
I think so too. Listen, we haven't
More
done
inflow.
one. We haven't done one, so that's always a good thing.
So now you want us to separate those wires before.
We have a look.
That's okay.
Okay,
That's
right there.
okay.
That's good. No, too high.
I know.
Do we have the ruler so we can use that as
Yeah, I need the
reference?
ruler. Hold on, let me see the
I
difference.
can't.
you.
I can't even do it.
Yeah,
Eliminating or reducing steel. You
yes,
can only do it at
With
the
the ruler in front, so you could,
but the low crossover, we don't know if there's enough pressure to drive the PCPO to it, drive we don't.
Okay.
15, perfect. Deploy that, please. Deploy the filter. So we're going to deploy not the filter, there you go.
The
Perfect.
capture.
Right there, the vein. Now we're going to go with we're going to go with the device.
PK,
Sir,
is there any chance that you could inject some contrast, not on DSA, but let the contrast hang on the vein?
yeah,
So
we
we
can
can have
inject
an
through the
idea
side
how
port,
close
side
it is
port
and
of
we
the side port of the whatever, the
see.
snare. So Jid, you got the wire, bro?
No wire yet.
No wire. All right.
Okay.
Keep going. It's okay. Click on.
It's not coming.
What's happening with your wire? Why is it not coming?
Okay, hold on. I'm just pulling it to you.
The wire's up there.
I got the wire right here.
That came back a lot.
Uh-huh.
Yeah.
I'm just going to advance it. Okay, good. That's perfect. All right, here we go.
Okay. That's the contrast into the vein if you're looking.
Yep.
Where's 15? There you go. That's it right there.
15 is right there.
Okay, let's inject from the artery from above, guys. I want to make sure that we're at the trifurcation. Inject. Okay, a little lower. Actually, that's pretty good.
That's pretty good, no?
Yeah, that's pretty good. Let's see if Steven's right, whether the length is good right there.
Yeah, it looks promising, PK. Looks good.
Let's see.
I was mentioning that sometimes you can see the needle touching the
There you go.
anterior wall.
It just touched.
I think it is, yeah.
Yeah, we're in. Yep.
Yeah,
it's
yeah.
in.
Okay.
Yeah, it's
Give me
in.
the wire, please.
So are you feeling when it hits the needle?
Yeah,
Yeah.
that's what we feel.
Yeah, there's resistance. You feel it with the snare if you pull it back or forth. It catches.
You want to show it?
You can see the needle move a little bit.
Right there.
I'm gonna just walk back a little bit, see if it pops in. Hold on.
When you change this angle.
Nope, I probably didn't go through and through.
Yeah, that's better, no?
Let's see. Huh.
Let's just double check there as well.
Yeah,
Yeah.
it is
No,
definitely.
I don't think I'm through and through yet. See, I'm too far away.
Huh.
Now I'm in. Ooh, there you go. Now I'm in, I think. Now I'm in. Nope.
Watch your legs.
Your options go a little bit more south, PK.
Yeah, I'm just trying to see. I mean, we hit the vessel, so
Yeah. It could be because the artery and the veins could be separating at this level because they
Yeah,
are
it could be a little
anomalous.
bit more south, might be better.
So
mm-hmm.
if you hit down a little bit more,
Right there.
Okay.
No, a little bit higher if you can.
Yeah, a little higher than that, I agree.
Maybe try to get the
Pull back, no, PK.
two of these
Little bit.
catheters to be completely
You want a
side
different
by
oblique?
side.
Yeah.
To separate the.
Probably other way.
That's worse. Watch your knees.
Watch your knees.
Sometimes the arteries and the veins spiral around
Watch your legs.
each other.
PK.
I think this is pretty good.
This is pretty good.
Yep, try that.
You can kind of move along with the views, or you
Yeah.
prefer?
So you get, sometimes the vessels spiral.
So you
wanna
don't know.
get-
Can you see if I'm
Yeah.
caught?
Almost looks like it's
Yeah, you're
bouncing off the
caught.
calcium,
I
right?
can see your.
Yeah, but it's not going, Al. That's the problem. It's interesting.
Are you caught? That's so
Yeah,
strange.
we are caught. We are caught. You can see the.
No, you're not
No.
caught. No. Go back up.
That's what I'm thinking. I don't know if you're breaking through the wall or the artery yet, right? Because it looks like it's still within.
Yeah, I agree.
I think we're a
Mag
little
up
off.
Might help.
Yeah, mag up a little, guys.
PK, sometimes what you do is you puff some contrast and try to use the needle to tap the vein wall.
Oof, look at
See,
that.
but
Yeah.
now you're actually pushing the
I'm actually
snare.
pushing, but I can't perforate the wall. See?
But you might be through it though.
I don't think
Does
so.
it go?
It didn't feel like I went through, see?
Want to use a stronger wire?
Can you push forward with the needle out and like
did,
see
I
if it
tried that
pumps?
Yeah, you
before.
can. Yeah, push forward a little bit.
Yeah, that's better.
That looks like
I'll
you
try
went
it.
farther in.
Probably a phlebitic vein is having a hard time.
There you
That's
go.
better.
All
That's
right.
better. That's
All
better.
right. So let me just walk the needle back. Hold on. Oh, okay, now. See if you go.
Let's see if I can
Uh-huh.
get it.
You,
Are you snaring it?
I'm
I
trying.
don't think so. Looks weird.
I can't. Can I see?
Looks a bit weird.
There you go. There you go. Nope.
You know, the basket's not fully collapsing, but it has it,
Can you pull it back?
which I think is okay, right, Grace? You can still take it kind of partially in and out.
It's not collapsing?
So it's not collapsing because there's, I think the wire's
There you
just
go.
There
kind
you
of.
go. I got it. I got it.
Okay, or you
Wait,
just.
hold on, guys. I gotta push on this side.
Okay.
Okay, go slow. Low on
One
your.
second.
Just follow us down.
Okay, keep pulling. Keep pulling. Keep pulling.
But it's, see, the basket's still a little bit out, which is okay.
The problem is the sheath. The slender sheath. I don't know if you'll take it. One sec. One sec.
Oh my God.
Hold on, I haven't been.
Okay, go. Okay, through and through.
It's going easy.
Okay,
Yeah.
good.
Yeah.
All right. So now on my end, once they clamp this, I'm gonna pull this out.
Getting this
Mosquito?
No, you don't have to worry about this.
Yeah, yeah, no,
Just
I
clamp
got
that. Yep.
one. Yeah, I am.
You just got to pull it out for me.
Yeah, I know. It just.
Sorry if it
helped.
breaks.
Yeah, I think it's just the wire got destroyed. That's why.
Yeah.
1 second. 1 second. Don't pull it.
All right, so now we're through and through. So now we're gonna create the fistula. Get me a 3/0 balloon, guys.
I have to cut this wire.
Gotta
You want- you wanna hold it?
Yeah, just cut it where it's fluffy.
Yeah, like really hard.
One sec. Okay. Oh, there you go.
Oh, nice. Even better.
Even
All right, 1 second.
better to be lucky than good.
All right, so I'm just gonna pull this out now.
You can get rid of this one, right?
Yeah.
The sheet's way back. Show me the sheet.
Okay, got it.
That's fine.
That's pretty good.
Take it out.
What do you do with the sheath in the lateral plantar vein?
Right now, it's just there. All right, guys. So give me the balloon now.
Lateral plantar vein still in? Yes.
Yeah. So Habib, when I ask for it, I want you to open it, bro. Ready? All right. So we're gonna balloon this now, and then we're gonna get the. Now, Stephen, in this case, would you still balloon and stent, or would you cross first?
I like the cross first. I mean, I always like to get my wire across. Then most of the time, everything will follow through. You know, so I like to cross the sheath and get wire right across, or 1/8 wire. But that's me.
I don't know, Jit. What do you think?
You do what you do. You do.
I think
what
this is very difficult. I think we're gonna
cross.
probably do our technique. We're gonna
Yeah.
stent and then go.
Sure.
Mag it up, bro.
Sure.
Oh, you mean crossing into the foot?
Crossing into the foot.
Mag it up.
Yeah, I would go proximal to distal and just fix that first.
At 20.
Okay, right there. Go up.
Where is it? Oh. So there's the same size, like 3/0?
3/0.
Three.
There it is. So that is about
20. Right above 20.
right
19.
about 19, 18, 20 atmospheres.
I am.
Okay, down. Okay,
Nice.
good.
You have a command wire or a grand slam?
Grand slam.
Grand slam. Do you want to take a picture now and just make
Yeah,
sure there's no extra?
ready? Picture.
All right,
DSA,
go.
DSA.
It's on DSA.
DSA, please. Okay.
Yep.
Okay, very good. No extra. All right.
It's a big vessel.
we
So
got- now we're going with a
valvulotome
5-0
first
balloon.
or balloon?
Going with a 5-0 balloon.
Okay.
220.
220.
So in case you have extra and your sheath is up in the SFA, what is the next step?
I mean, honestly, we've not had that much extra. I mean, we have ruptured it, but we just go ahead and just put a covered stent in and then start working. That's all.
Okay,
Ajit
so-
and I have had ruptures of the vessel. We just put a covered stent in, really.
Yeah, I guess you'd just maybe deploy the proximal stent first if it's really bad.
Okay, got you.
Can we distal, guys? So the idea here is to take this thing as far down as you possibly can. And I try to take it right across everything
Yeah,
here.
I'm gonna pull the sheath back a little bit in the foot.
Uh-huh. I think we can go up to here.
That's good.
Ready? Let's see up top. where
To
we
the
go.
level of that bend, right, PK?
Well, let's see up top. That's where Steven doesn't like to go, right, Steven? You don't like to go across the calcaneus.
With the balloon?
Generally speaking, unless I'm prepared to put a
No, stenting, he said. He does not like to go.
All right, so we'll stop here. Go up.
Yeah.
Go up.
Just below the upper border of the calcaneum.
You can
Slowly.
see actually the vein. You can
See, that's the valve right there, guys.
That's the medial vein here.
That's right.
I like the line that's.
We're probably gonna rupture this vein.
I just go into nominal. What is nominal?
6.
Uh-huh.
6. Nominal.
What is nominal, guys?
But you see how the end of the
Yeah,
balloon is
look at
much
that.
bigger than the
Look at
rest of
that.
it, so it's not a 5 vein. So
So what are you at now?
6.
So Steven, we're at 6 atmospheres. Should we go any higher?
Yeah, I think we should just.
Yep.
You have to bust
it's the
everything,
valves.
if not the stem
Yeah,
graft.
keep going.
Not gonna come down. You have to bust everything. Is the wire down the arch? The wire is down in the lateral plantar vein, but it's exiting through the sheath.
he's gonna
Yeah,
feel this
pain.
part.
Yeah. Give him something, he's going to feel it.
This part is always painful.
You know what, sometimes what you can do is you can inject dilute lidocaine through your retrograde sheath into the vein. And let the lidocaine flood the whole vein and, that helps with the spasm and.
Intravenous.
Also helps.
Go up a little more over there.
Intravenous
Dilute
lidocaine.
maybe 50 milligrams
Opening
in a.
Yeah, it's
a
opening
large
up, it's just the
volume and
valve.
inject it into the vein.
Keep
Let
going.
it- Let it dwell.
No, there you go.
Yeah, keep
Better.
going.
Almost there. It's just taking time for it to space out in the vein.
Get the covered stents ready, guys. Give me a 6-0 long, the longest one, 5-5 longest one you have ready.
So your kit comes
Yeah.
with a 5.5,
Keep going.
200.
5.5, 200.
200, yeah.
Right?
And a 200 and a 150.
That's
Okay,
better.
we
That's
gotta go.
better. Couple of valves. Couple of valves.
You want to run the valvulotome real quick first?
Yeah, I
no,
would.
We're gonna rupture it.
At
Go,
least here.
Go up here.
Calvin, try not to move, my friend.
Perfect.
Those two, at least you have to run the valvulotome. I'm at 12, 14.
So
I think-
this,
so-
PT DVA, what is your bony landmark as to how far you would run your valvulotome, PK?
We
To the
go,
level
we
of
go
the
all
cap,
the way
or
down
go down
now,
to the
all the way
foot.
down. You'll see we're gonna go very far down. But right
Very
now,
far,
the first thing we have to do is open this up before we put the stent. So we're gonna go ahead and do the valvulotome here.
Yeah.
Steve, and I think once this is not
Every-
opening, we're at 12
eh, eh,
atmospheres with a
yeah.
5-0.
Everything else seems okay
Keep going
except
up.
this two.
But yeah, we take the
Go up, PK, 14.
valvulotome down to the
Won't tear
pedal
the whole
sheath.
thing apart.
all the way as
Pedal
far
sheath,
down.
okay.
Yeah, as far down as we can go.
Won't tear the
Because
whole
there's
thing apart.
valves, you know, even below the
So we're
kind
gonna
of
do a
calcaneus and below.
valvulotome here, and then we're gonna go up here. We're gonna balloon up this spot here. The fistula was at 20, so we had to be careful not to go past it, right? Was it 20, guys? If I remember.
20, 20,
Yeah.
19, 18.
So we'll,
but
no,
20.
we'll stop
Stop at like
uh,
21 maybe.
Stop at 21.
Yeah.
Probably
It's
safer.
not down yet.
I know. Ultra-worse.
And in your experience, have you seen valves just proximal to the confluence of the lateral and medial plantar vein?
Well, there is a valve at that area, right? That Stephen was talking about. Go up.
Yep.
Yep.
So is
there
that why Steve prefers to get the 018 wire across, do the valvulotome, and then deploy the stuff?
Well, not really.
This
I
is
mean,
good.
That valve,
This is good.
that valve usually requires.
Yeah, this is good.
Oh, it's going to be ruptured, so let's go fast here.
So I think
Everything ready with the valvulotome?
Valvulotome's ready.
Okay, 1 second.
And the stent's open.
I don't think it's going to be
No,
ruptured.
let it come down. It's not
No,
down.
no, no, no. I'm not pulling. But I don't think it's going to be ruptured.
It's not down yet.
No, no, I'm not pulling. I'm just waiting for it to come down. Let me take 1 second. I got
Let's
this.
go negative again. Yeah, it should be fine.
Have you tried it this way?
in the past, yes, I did. Yeah.
So, what are some other tricks that you would have if we can't open up the valves at this point where you just go straight with a high pressure balloon? Would that be the next step?
I normally go short, high pressure, followed by
Oh, turn it around.
That's
Let's see.
because it's if it's going to be covered by stent graft, you don't have to be too gentle with.
Yeah, valvulotome?
You're just going to end up covering it anyway.
Get the Silver Hawk ready. Get rid of this balloon, please. All right.
Off label.
It actually works though.
It does. It worked up with us.
So how
I don't
far
know.
down did you
I
get
don't-
that silver hawk?
We were across the ankle. We were in the foot.
Oh my
We-
God.
Yeah, we just had to go ahead and just get it open. I sent Steven the photo.
I don't know how you bill it, but
We built it though. I'm joking, guys. Or up top. We don't need to go all the way down. Up top.
Yeah,
It's a
just
forward
go-
cutting, right?
Yeah, yeah.
So
yeah,
let's
yeah.
go about
Start
here.
from there, from the
I'll
above
give
the
you
ankle.
through and through tension.
Okay, so I'm gonna just do the valvulotome here. So there it is, right there.
You start, send graft, the variables.
See, right here, I'm having resistance. It's
Yeah, I
not
think in
going.
this area,
There's always one
it's
there.
an area covered with stent graft, so not super beneficial to use the valvulotome here, but it's.
Oh, there you
I
go.
think under the foot would be.
That's
under the
better.
foot would be-
You want me to pull the sheet? Yeah.
No, I got it here.
Okay.
You sure you have this one?
Okay, we got it. Show me above. Yeah, it's done.
Yeah, it's done.
It's done.
Okay, how about under the foot? You wanna?
We did.
Maybe we can put a valvulotome under the foot. Maybe inject some contrast up the sheath, and you can maybe see the valve.
Give some dye in the sheath, guys.
Or you can inject dye through the valvulotome as well on the 2E.
Oh, we're just gonna give a little bit of dye here. Let it sit.
Yep.
A little dye. That's already open, so I'm just gonna go here
Okay.
up to here. Yeah, we got it.
We got it. We got it. That was the ankle one was
Hold
the
on, but
toughest
the valvulotome is not open.
Yeah.
That's the reason we got it. Ready? Let's do it. Let's do it again here. Pull the wire, guys, for me.
Yep.
Yeah, yeah. Both ends.
Wondering why it's going so smoothly.
Yeah, I was like, what the hell is that, Al? I was like, man. I've gotten good at this. I just loves when I do this because this is like my, oh man, this is so much fun.
You love being aggressive with
I'm
the
telling you, dude,
valvulotome.
look how aggressive I am. Okay, this is done.
You know, this is like his
You
meditation
keep
spot.
saying
You
you're
know,
done, but then you keep going.
Steven, I mean, that's just amazing.
Alfio, this is his Zen spot. You know, this is what he does. He keeps like
Stress
doing
release.
it.
So, Steven, yes, sir.
Okay.
What's that?
Is this a well-designed valvulotome or what?
Did you design it, Steven, by any chance?
Of course.
All right. So now we're gonna go with the balloon again, or we're gonna go with the stent.
Probably the stent, right? We already ballooned.
All right, stent going in.
So how far down though?
So I have a question.
Should we take a
Level of the
picture? Or?
calcaneus, no?
No, let's not take a picture.
Okay.
No, it's not. It's
No picture.
We didn't tear it.
We
Don't
don't
worry
want
about
I
it.
don't know if we tore it. It might not be.
Don't
No,
want
it's not.
picture.
Okay.
No picture.
All right.
I would go to the level of the
Wet one, guys?
calcaneus.
What about a little puff?
Wet one? No, come on, Ajit. Seriously?
Okay.
All right, puff it is. Go ahead, hit
No,
it.
no, it's fine.
Hit it. Hit the puff.
Take it, take it, take it. We
Oh,
didn't
I don't know
get
how
it.
to.
He's so comfortable.
This is on the
No, you
wrong
gotta
one,
do
right?
this one.
Get this one.
There's no way we tore it.
Go ahead.
Maybe a puff on
there's
the
n-
distal axis, you can see.
Oh yeah,
the
we got to open up the
plaque.
valve probably. Hold on. Well, too late now. We probably don't have outflow yet.
Yeah, ready? Real?
I got it. Above and below.
Show me above.
You can consider
area
puffing from
problem.
the distal to see the junction of medial and lateral. You know,
Wow.
help.
So not going through. There you go.
I think that should be enough now, PK.
You like that, Steven, or you want me to come back?
Come back, no?
I generally bring it further back. You know, but
I know.
PK, you want to inject from below
No,
and see?
I agree with you.
You want to inject from
But-
below and see?
Why not bring it down this far? Because then you cover all those extra branches that could steal.
But he's saying we cover the medial plantar.
Mm.
just you do have the first
Inject from
toe
below?
wound, and
Uh-huh.
you know,
Mm-hmm.
That's a good spot.
That's a good spot.
That's a good spot.
so do you guys see the medial plantar? If
I
you
don't
do
s-
that frame by frame. You can see the medial plantar.
No, I think it's a little bit above.
So I'm
You
going
want
to
to
pull it back then. Right there.
Yeah, a
Ready?
little bit more above, PK. A little bit more
A little
above.
bit more above.
Yeah.
Yeah.
You'll see it now.
Right there. Ready?
Yeah.
Okay.
That's a good spot.
Yeah.
You see it?
That's a good spot.
So where do, what,
I can't
where's
see
the
it.
medial
Right
plantar?
there.
Show me up top, Karthik. I want to make sure I'm not too high. Up top, all the way up top.
No,
Okay.
No,
you're
we're
good.
What size is that?
5'5".
The one. Did you come back a little bit?
I think
Yeah,
so.
he did. That's good, PK. That's a good spot. That's where the dye staining is. Even back a little bit would not hurt.
That,
Does the stent look a little? We'll have to iron it out.
yeah, there's that leg, it looks like one of the legs or.
Yeah, we'll iron it out.
We'll iron it out.
Yeah.
Okay. Well,
Wow.
uh,
That's interesting.
Supera. Yeah.
Pull.
That's interesting. I've never seen that happen.
I've seen that.
Show me down.
I think the stent looks a bit.
I think
So
we should
you
have
ballooned
kept
it
some
before,
tension
right?
on it.
Yeah, we did.
You did?
Some
Okay.
Yeah. All right. Give us another stand above.
You want to move the ankle a little bit? That might help stretch out the stent.
Yeah,
give us a, give
that's
us a
exactly
50
that's what I'm doing.
150 balloon, guys. A 50 150 balloon.
Fluoro, PK. Fluoro.
That's fine. You can take it out.
You want to stent the other one
Ankle a
first?
little bit.
Stent first, or?
Yeah, let's balloon the ankle first.
Okay.
50 150.
Karthik, you just exercise the ankle.
Yeah, that's exactly what I'm doing, Steve.
Because it does look like.
Yeah, it's a little,
What does it look like?
Maybe you can.
looks like
It's just
it's
not
collapsed.
straight.
It's not
It's
straightened
fine.
up. It's like enfolding on itself. But it'll line up.
Once you balloon, it'll line up. All right, ready?
It's probably because we ruptured the vein.
Why do you keep saying the C word?
Because it's just
You love saying that word, huh?
the C word? R word?
You love that word.
Well, it's. I don't want to. I'm saying it's not your technique. It's a compliment.
It was my valvulotome that did all that.
Yeah.
We got the wire. Anybody got the wire? All right, let's go down and just balloon this and straighten this out.
I got this.
Thanks.
All right, great. Let's balloon.
You're. That's first dot or second dot?
That's second.
No, that's the
Good.
second
Oh,
dot.
you're in the sheath.
Yep, we're gonna pull back a little here.
That you see the dots at the end of the
Yeah.
bottom of the foot.
No. Is that it?
Yeah.
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 Wow. That's pretty damn good, man. All right, ready? Go up.
Called aging PK.
It's called aging. 20 hemispheres. Okay, good. All right. Okay. Down. Oh, I know. It'll be better. I promise. Okay. Let's come back a little here. Okay, go up there. Great. 20 hemispheres. Beautiful. Down. And come back a little bit now. Go up. Okay, good. Down. All right. So this part, now we're gonna put the anastomotic stent in.
Down. Wait.
No, we need one more. Yep.
Mm-hmm.
Yep.
Is it 150 you're taking or?
Yeah, that's what we got, Stephen. 155, 150.
Are we thinking about putting drug-eluting stents all the way to the origin?
Yeah. We'll do that at the end after we do the alluvia.
Yeah, so we don't catch it.
Yep.
Are you guys trying to match the price of the first case?
Oh my God.
We have some ways to go before that.
We still
I
are
got
okay
this.
here. Pull both wires, guys.
We got it. I got the one wire. Ajit has got the other one. I got both.
Okay, let me show me above now. 20, is it a 20? Okay, this is, so I think come back a little
Come
bit,
back
right?
a little
Yep.
bit, no?
Yep.
That's good.
Right there. Okay.
We have enough overlap,
I
right?
think we have covered distally nicely. Yeah.
Oh, yeah,
Yep.
plenty.
Okay.
Is that another, like, 5.5 by, what's
It's a
it?
5.5
PD?
100, I believe.
PD?
Is that a 5.5 by 100?
120.
Is it a 5.5 100?
You can watch it. It's dropping
Is that
down.
the one that comes in the kit?
They have a variety of stents that you could ask for, depending on the match the length.
Oh, they're all covered.
Yep.
Yeah, we have a 100
Good. Stent looks
millimeter,
nice.
but normally it's in the.
All right, give me
it's
the
in
other
packs.
one, that tapered stent.
Mm-hmm.
That's the 3.5 by 5.5.
So it's around 19, you guys said, or 18?
PK pressure is a bit low, PK.
Yeah, they're a little low. They're dropping again. No, they're up and down.
Do you want to?
The groins are really good.
Calf is soft.
Calf is soft.
Calf is soft. I think he's just very well sedated, Stephen.
And he's a dialysis patient, so he probably always lives a little bit on the low side.
Do you want to take a picture, or are you confident where it is?
I think we're good. Oh, we'll definitely take a picture. Are you kidding?
Okay.
Show me above here. Ready? DSA? Ready, guys?
Yeah.
Oh,
Where is it?
I think it's right there, right?
Right there.
Around 19,
Around 19.
18.
Okay.
might be a bit short.
We're going to be short.
Yeah.
Rail?
This is 6 centimeters, right?
6. I think a little bit short.
We crossed it somewhere at 19.
No, we're good.
Oh, that's good.
We're good.
We are good. We're good.
Yeah, we're good. Deploy, Karthik.
Forward. It looks like a good spot, no? What do you think?
You want to overlap more? This is good, right? This is good. Go.
This is just
Just
about
right. Yeah.
as little as you can overlap.
Minimum overlap.
Well done. That's good.
Beautiful. Walk it out now. Mm-hmm.
Well, you probably have about 1 centimeter of
Yeah.
into the artery, but you're gonna
DSA?
secure that with a couple of metallic drug-eluting stents anyway, right?
Mm-hmm. Yeah, beautiful.
Good.
We got it.
Very nice.
Nice.
All right, very good. So now let's balloon this. Give me a 3.5, 4.0, 2.10 balloon. 3.5. We'll balloon this first, the transition, and then we'll go ahead and balloon it with a 6.
PK, maybe just a 5 PK.
No, I'm just gonna do the proximal aspect with a tapered balloon if they have it. You have it or no? 3.5, 4.0 tapered. All right, you know what? Forget it then. Then just give me a
maybe a 5 only because you had that fabric tear from the last case.
So you know what? Just give me a 5.0 long and a 3.5 balloon. 3.5 40 balloon and a 5.0 long balloon. Yep.
Tommy, not sure why the first page there was a page so we have to do that. I don't know what. I've never seen this before.
We've already texted.
And a 3.5 40.
Already texted the engineers and they're.
No, it doesn't matter. Could be peripheral balloon.
Let's look at. I don't know why. This is the delta, is that right?
Keep going.
Could be right. It's a 200, so it's a delta. It's a delta.
What do you mean?
The version of the stent is the delta stent.
Yeah.
Oh, it's good, PK.
Okay, let's balloon this.
You want to go down to the distal overlap also
I
once?
think we got it. Yeah, we're good. Go up.
Is it a little lower? Or?
Yeah, go low.
Yeah, that's good.
Yeah. And then, no?
Good.
Stephen, is there any origin of the tibial artery that you would say is too small for a DVA, or there's no absolute size cutoff?
Down.
Well, I mean, the results
wait,
we've
wait,
had so far are all 3, 5, and 4s on the top, right? And they're all
Up here?
proximal, so I really couldn't tell you.
A little bit more, no?
Yeah,
No, it's good.
2, 5, or 3 would be fine.
I don't think you got it, PK.
No. Osteum we had to do with the 3.5. I know
Yeah, I
that.
know.
That's perfect. Go to
I see.
10, 20. Get down. Down.
They're all 3.5 or above, right?
Yeah, but sometimes they're small and diseased. Yeah. No, we'll encourage people, we'll put in, if they're badly diseased or is a flush occluded, if you do a subintimal section, we'll always put a drug-eluting stent well into the TP trunk.
Okay.
And then post-dill that and have that secure, and then if you need to do a kissing on the peroneal.
Not down yet.
Should be out.
No. All right, and the 3.5 guys. Mm-hmm. No
Yes.
wire?
No, you can just keep going. Get the wire.
Got wire.
Got wire? All right. All right, let's go up.
Ajit, just come forward.
Yep. Hey, that's 8.
10, 12.
12, 14, 15, 16.
Right, down. Want to go a little bit? We're going to go
But a
up higher.
3.5, my friend?
Yes.
Mm-hmm.
I'll go to 20.
Okay.
Good. Down. All right, good. All right, DSA guys, just to make sure everything looks good here.
Yep.
Nice. Nice.
Very good so far. Now give us the Navi Cross, guys.
You want to just shoot the stents ones?
Oh yeah,
just to be-
100%. Ready, bro? Mm-hmm. Mm-hmm.
Good. It's going somewhere.
Ready? Inject.
There is no stalling of the dye. There's no dye stasis.
Oh, nice.
There's the medial plantar.
Very nice.
All right, good. Give us the
Beautiful
Navi.
spot.
If you look at the vein behind the covered stents, that is a short saphenous vein coming back.
Do you want to?
Just behind the field. 'cause
Yeah.
it's-
You want to see the whole thing or no?
Huh?
Yes.
You want to see the whole arch or
Yeah,
no?
we cut. Ready? Inject now.
Go for it.
Nice.
All right, give me a command wire, guys. Try to go side by side.
So PK, if you look at this image frame by frame, the perforator in the mid portion of the foot actually becomes the short saphenous vein. You see that?
Yep.
So sometimes you have to embolize the perforator. You hit the short saphenous vein, you come from the top because the perforator comes out at a very oblique angle. It's hard to get a catheter in. So sometimes you hit the short sap and you come down.
Almost like a reverse curve going on.
Yeah,
Oh, you gotta come back with your sheath a little. Okay.
I did.
All right, give me the wire now. Let's see if we go side by side here. Rail the wire, guys, for me a little bit.
You want to bend?
Okay, real.
That's all I needed. Yeah, you do need a little bend here to get through that curve.
Plantar look. Yeah.
So I'm going with a command again. I really believe the Cyan Black is the best wire for this. But what do you use, Steven?
I use a PD2 wire, a very floppy wire.
PT2.
Yeah, very.
Do we have a PT2, guys?
I can use anything, PK. You'll be able to get past the arch.
No, I'm just curious.
Or the coronary version is called PT Graphics, but that's a 180 length or something like that.
Yeah, keep going. That's it, no? Pull back a little bit.
If you inject contrast down the
sheath from the retrograde sheath, yeah.
Yeah,
That's what I was thinking.
because the flow is going to push it forward towards.
Mm-hmm.
Inject. You ready to inject?
I did.
The sheath
I
come.
think
The
the
sheath
sheath is
come.
a bit
Sheath
extra.
out.
The mech sheath is out almost.
Yeah, sheath is out.
Sheath is out. Just leave the wire. Let's go AP on the. Oh God, his foot is so bad. Oh yeah. I know. Oh, please. Oh.
Okay, I normally use a 2.6 French support catheter rather than a 4 French.
All right, we'll do
Or
that.
even a balloon.
Give
or even a
me an
balloon that will
018
help to follow the
Trailblazer,
balloon.
guys.
The sheet's
018.
still in from below, right?
No, it's out.
Is that?
Yeah.
We have a Trailblazer.
It's still plugging the hole, but it's out of the vessel.
Just that you have it wedged. You have it wedged on top, right? So it's holding it.
Exactly.
So, yeah, so that's what I do sometimes. I use the sheath to plug the hole and then take the sheath out and then you can use, so you don't lose too
There you
much
go,
blood.
PK.
You have it?
Yeah.
Mm-hmm.
You have the command wire?
It's right there.
You want to try a Cyan Black?
I don't think we have it.
We have.
No.
We don't have a Cyan Black? I mean, you can always use a 150, no? Once you
No.
cross it, you can take it wire out and then change it.
No, I can't. Show me above,
Bent
guys.
his leg again.
Actually,
You use a Fielder FC, right? Which is like.
PK,
a
1 second.
black.
I got it. Hold this. Let me straighten up his leg.
it's okay. This is a good view.
Prakash,
Yep.
you have a fielder FC, which is similar to the cyan black.
Let me give some dye here. Let me give some dye through this. You guys have a little dye?
Yeah.
Fielder FC, Jose? We don't have it.
You know,
No,
even for CTOs, for transcollaterals.
I don't think we have a fielder FC, do we, guys?
It's the same thing, right? You've got to go through the arch and into the dorsalis.
Oof, that's not gonna be easy. Wow, Steven.
You want a you want a roadmap?
No, yeah, give me a roadmap. Let's see. Got it. All right, give me a wow.
This is a fielder wire, PK. You have to use a fielder wire.
All right, give us a fielder.
I'm going to cross this.
You're right, just fasten down.
Regular fielder wire and try to navigate and then change it to a translam or something.
It's spasm right down, huh?
You want to give some nitro?
Oh, he's moving like a banshee.
Banshee.
Yeah, I think you lost your own map.
What's that?
I think you lost your own map. You
Yeah.
moved.
Try this.
Any thoughts, Steven, on?
Yeah, I just let the wire do the talking. So
Ah, ha, ha.
I don't know.
I agree.
But it'd be nice. It'd be nice if it's an AP configuration.
good.
So maybe
That's
send
good.
the
That's good.
catheter down a little bit
Yeah,
into the
that's
arch and have it right against the loop. Then do a run over there. Maybe that would be helpful.
Straighten up the
but-
wire there, PK, and then see now if it falls in.
But it should go through. It
Should go through.
looks achievable.
I don't think that's it.
No.
No, that's not it.
That's not it.
It's probably
Aye.
gone into some. Wow.
That's the vein for sure. Okay, you want to run it and see?
I'm just going back. It almost looks like there's two channels, a smaller one and a bigger one that's more distal. It's kind of looping back into the distal one.
Mm-hmm.
Try to take the second one, PK.
Nope.
That's better. That's
think
better. That's better.
That
Like
might be the bigger one.
Yeah, that's a good one.
Yeah, there we go.
You want to get your catheter down?
Like that.
Mm-hmm. You want to use go over the
I
second
think
bed.
that's it.
I think you're in a superficial vein for some reason. I'm not sure. It looks a bit odd.
You want to inject from there and see?
Yeah.
I'm gonna inject from here. Nitro, guys. There's a lot of
Any
fun,
way
huh?
you can get a way you can get an AP of the foot.
You know, this gentleman is a very, very demanding gentleman. He likes his positions. Looks like I'm in the loop there. Let's see. Looks like it. Nitro, guys.
You want another command wire? Command wire?
Yeah, give me another command wire here, guys.
A bit more oblique.
It's okay. I know this is
possible.
nitro. It's okay. You can do it later. All right, ready? $200 a nitro flush.
You have the contrast there, right? Or no? Mike, give some contrast in a small syringe to begin.
All right, let's take a look here. DSA, ready?
You want to do a roadmap or DSA?
DSA, Cindy. That's the loop.
That's a loop. That's the loop. You do a roadmap and then go PK. No.
I'm not able to get into that. How am I going to get into that?
It'll take it. Take the turn. Optimism. How are you going
You have to
get
pull the catheter back a little bit,
I'm
right?
going to, bro.
Yeah.
As soon as I go down, I'm going to pull it back.
How are you going to get into it with optimism?
You're so positive.
What's that?
It would be nice to see a full AP of the foot, but recognize that.
I
I mean, when we
can
did
do the full AP
ESA,
if you want.
We're going to kick over the pedal.
I think his DP is not non-existent. I think it looks like a tarsal. At least on the first few angiograms, maybe that looks like a tarsal rather than a DP. So there is a possibility that the DP artery is absent and the DP vein is also possibly absent too. So, I mean.
Now it's coming back to the.
That's a good one.
There it is.
That's it.
No,
That's it.
no.
No, it's
That's
a
the
different
short
one.
loop, Steven.
Yeah, weird. It looks weird.
No. It's the short loop. I'll show you. Here, watch this. Okay, give me some dye here, guys. I don't know.
I don't know.
Is that the sapphire? No.
Yeah, it looks like a great sapphire.
Do a roadmap PK.
This is dye.
Fluoro and see.
That's saphenous, right? Oh, there's the DP.
I think I gotta traverse that. I don't think there's a DP here.
Yeah, that's a possibility, PK.
I don't think there's
Why
a
don't
DP.
you put the wire in the medial marginal and followed by the great SAF and use that and then just get the flow going and maybe probably have the balloon put the wire first.
Give me the wire back.
Put an 18 wire or whatever wire you have after you cross it.
Roadmap it.
And then just work with it first.
Go for it.
Let the flow run and maybe you'll be able to get it going later on.
Roadmap again.
So what do you think that vein is all the way to the right then?
That's a short saphenous. Looks
For
like.
saphenous?
Like it just fills through the medial plantar
I
as well as
really
this.
don't know, but it does look like the short because it's
Short,
natural.
Yeah. At least the way it traverses through, it looks more like a short saphenous.
Wet one, guys.
I think your own map is not gonna work.
Okay, off roadmap. Yeah, we opened it up. That's why. I'm sorry.
That's good. Now you can see it. That's a good. That's where it was. It was okay, PK. If you can get into that. No, where the wire is right now. Of the wire.
That's the vein going to the toes. Yes.
Keep it here.
I think that looks good. Maybe change that out for 18 wire and then get a bit more support.
And do what? Okay, so I'm back in the short saphenous here, Stephen.
No, that's a great SAF.
Let me see. It looks like the short. Let me see.
Looks like the
Oh,
short.
it's on the other side, PK.
Let me just take a look. Convince myself. Give me a V18, guys.
You want me to change the angle and show you?
Yeah. Oh yeah, you're right.
It's a great saphenous.
Yep, I see it.
Sorry. Yeah, it's a
Yeah,
great
it's
tap.
a GSV. All right. So are we going to accept this, or are we going to go for the? There is no anterior tibial vein here. What are we going to go after here?
Yeah, I think just let it run first, get the circuit to get the blood down, and maybe you'll open up, and once you have flow going down, you might be able to see a stump or something like that. Just let it run.
All right, let's go. Okay, get us a 4-0 balloon, guys. 4-0 long.
So then your alluvius will go down where?
I'm not sure if it's gonna do it.
Okay.
This is not an alluvia case, Jose.
But not always you have to put an alluvia after your DB stents.
Not always, but if it doesn't look good, I will have very low.
Wow. It's too stiff for the V18. Looks like.
Yeah, try a command 18.
Command 18, guys. Command 18.
If you're not putting alluvia, why do we need an 18 wire, PK?
The balloon.
But we can
Create
use
the circuit.
but we can use 014 balloons, right?
Yeah, but we still haven't created a circuit though.
You put the alluvia if it doesn't look good.
But you can always do 014 balloons, right?
Because that
014 balloons go until like 5 and
In
4.
case we do an alluvia, we might still do an alluvia in the
Does that one
proximal.
look
Can I have the wire, please?
How do you feel about a Supera? Might track better.
Yeah, but he said he's done Supera. It's not working.
Alluvia, because you said it looks.
Command
good.
18 or V18?
Command 18.
I haven't seen the contrast.
This is command?
Okay.
Because once that vein looks decent, maybe with the valvulotomy it looks
Dude,
decent.
I asked for a command 18.
But if it doesn't look good, then in my practice, I would put it.
Now, if they cannot get the wire through the loop into the DP, then, I mean, AT, then what?
ACT, brother.
So, if they cannot get the wire through the.
What was the last ACT?
The aim is to get the blood
But when?
into the arch.
Yeah,
So
what?
since you get the flow going first, and you might see a stump that be able to wire.
Yeah, just draw it again in
Sure,
proper.
The purpose is to get enough wire so that you can
Got
have to get it first, then decide if it's worthwhile for you. For you to
Interesting,
do
huh?
this. I don't know, is that a tussle or DP? I really don't know.
So even if you don't have a DP,
Wow.
just a DP, this is still fine.
Nice.
Yes.
Okay.
Is that a command 18?
Yeah. Yeah, walk it up.
I got this.
So I found that the V18 can sometimes give a lot of spasm. So
I think we
Yeah,
can lose.
but-
I think we can lose the through and through wire now. No.
You want to get the
Yeah.
balloon across it, and then
Yeah.
And
we'll
then,
tamp it on it.
then lose it.
So we're gonna get the
Okay,
balloon.
I'm a bit concerned about how those stent grafts are looking. It's looking compressed. You know what I mean?
Where, bro?
Because I think he's bending his knee a lot, Steve. So I
So the
also,
twisting, the stent grafts, they're normally straight looking at this location. So maybe see what it looks like, the mid portion where that normally they're straight looking. So I'm not sure what happened.
This is an 018 or 014 balloon.
can I have an
Dude,
018
I need an
ultraverse?
018 balloon. You give me an 014 balloon.
018 4 4? Yeah, 4. Cool.
What's your concern with it, Stephen? Even if it's a little redundant, though.
Yeah.
I'm sorry
it's
about
weird.
that.
I'm just concerned that the graft inside the covered stand is infolding because the covered stand looks a bit compressed in. Telescope looks a little bit. Doesn't look.
I can IVUS
maybe
it. I can IVUS it.
post deal, it looks a bit better.
We can definitely IVUS it, Steven.
Got wire.
Okay, this guy's moving his arms.
Don't worry, kink go down there or what?
The wire, it looks like a double.
Give you a little more tension.
No, bend.
If this kink is gonna have trouble.
See if I can straighten it.
Is it not going?
It's going a little bit. Yeah, it's making progress. Okay, hold on.
Okay,
Wire.
All right, we're gonna balloon this here with a 4-0. Slowly. Okay.
So PK, you're ballooning beyond the arch, is that right? Or a little bit of the
Well, don't you think?
between the
Is this okay?
Oh,
mean,
should
to
I
me
pull the
this-
sheath out?
I think this. We still have the sheath in.
Yeah.
Oh, we have the sheath.
And the
in.
wire. Might as
And the
well
wire.
get
We're
rid
gonna
of
lose
the.
the wire now. So I'm gonna come back with
Listen
the.
to the GSP.
So Stephen, you wouldn't balloon this far?
I think maybe come back maybe before the second bend.
Right there?
Yeah, just a little bit. Yeah, I think that's okay for a start, and let's have a look.
Okay, let's go up. I've always ballooned across it. Maybe that's one of the aggressive things. It's too expressive, maybe.
Yeah, that's
Low
4.
pressure and see what it looks like, and
That's at 4.
Can I get a monochrome? 4-0 monochrome.
Can we get a 4 monochrome suture, please? Monochrome suture. 4 That's 4-0. Okay.
I think it looks pretty well
Well, it's
expanded.
pretty good. Down. Gonna come back and balloon again.
Yeah, hey.
Okay, go up here.
Yeah, it's 4.
See if I can-
You don't want to balloon into the GSP.
Okay, down.
Yep.
you
Picture?
could end up
Yeah.
injuring the baby.
Yeah, you can open that.
Try not to unless even if you're gonna balloon it, be a bit.
All right, ready?
Yeah. Do you mind if I put that
Ready,
stitch
David?
in? It's gonna ooze.
That's good, PK.
I think I'm now in the DP. I think I'm in the 18 now. No?
No, you're still in a great sack, my friend.
Yeah.
Oh yeah.
Yeah, I
Still
see
in a
it.
great sack. Question is the distal vessel decent looking to leave it alone, or
That's a good question. There's enough branches going distally off of the loop, right?
what are you thinking of doing, PK? Is this acceptable?
I mean, I want to just take a better look at the distal area. I'm going to have David inject. And I'm sorry, sir. I got to see this. Okay, David, ready to inject now? Sorry, sir. Oh God. Impossible to tell. He's moving so much. Okay, one more time, David. Inject. I mean, the distal vessel looks pretty good here. A little bit of bleeding, but that's okay.
I think his DP is gone. The DP artery is gone, and I think the DP vein is gone as well.
So would you
Well, the
would you alluvia this or no?
Yeah, so I don't think there's a lot of benefit to try and wire the AT vein. I think the DP vein is gone because I don't see the DP artery. I see calcium, but the flow is down the tarsal. So the question is, the lateral plantar vein, is this good enough a result, or you want to scaffold it, or you want to balloon it in a drug-coated balloon, a larger balloon, that kind of thing?
Well, I think the only question is, do you want to scaffold the lateral plantar vein and leave it with a alluvia and be done with it, and then do the proximal?
The flow is pretty
That's
good.
pretty good right there, Stephen. I think just scaffold the lateral plantar vein up to the, and then leave it.
No, I think the DP's too much.
Yep.
More lateral, right?
So give us a 6-0 long scaffold, please, of
Stephen, why is it, that's not the
Illuvia.
DP out there on the lateral pole? I know we're not a two lateral.
Some tweaks.
You don't think so?
Tweaks.
You don't
Those
think
are
that-
tweaks. I don't think that's a DP vein. The DP vein usually comes in pairs. It doesn't look, it's too curvaceous, and then the DP artery is gone. This is where the contrast is hitting down. This is the, looks like a pass.
So Stephen, we're gonna do a 6-0 150 Illuvia.
I think a 120 might be enough, but you guys make the call.
Yeah, I think we'll do 150.
Okay.
What are the concerning areas on this that you want to do the Illuvia?
I mean, it's calcified here, but I don't see the veins. I'm not sure that doesn't look right, you know, so I.
Okay, pressure, guys. My pressure's low. I gave nitro. Remember that.
Maybe a
Let me
little bit
see.
past the cover. Right there, yeah.
It'd be nice if you could see a full
you-
AP foot because, you know, it's tough
Deflators
because
under there.
he's kicking everywhere. So I think you've got good flow down the arch.
Scissors?
So as long as you run.
You have scissors?
the lateral plantar vein, I think it'll be fine. So the real question is where would you end
Scissors.
it? Then would you end it here or would you end it here?
What's going on? He's not breathing now.
Needle.
It's okay to put an alluvia right across the
Alluvia?
junction with the
Illuvia.
medial.
Sorry.
It's okay to stent
Yeah.
across the,
Yeah, that's fine.
with a medial plantar vein.
Can you give me some 3548 Megatrons? Got it? Show me above, guys. Sorry, my dear. Okay.
Do you need to go that far?
I think that's good, Stephen, for me.
Yeah, it looks. Yeah, I think it looks good as well.
Yep.
You want to play the last run again and just to have a look at where the vein overlaps the bone?
We
Can you
can
use
do
that as
another
a
one.
bony
We
language?
can do another picture. He's sleeping pretty good.
Okay.
Might be occlusive with the stent.
Oh, we're occlusive with the stent.
Yeah.
Does it feel like you crossed?
We'll play the last one.
Yeah, that's.
Yeah, I see right where the wire crosses the bone. That is into something else, but I think you could probably deploy it there, maybe back by a couple of millimeters, maybe something like that. Because the
Probably-
stent's gonna jump forward a little bit.
Yeah, it's probably
Yeah,
better not to
somewhere
cover that branch,
Yeah,
right?
somewhere around there, I think.
Yeah.
Yeah, I think you got it. And you're probably gonna need to take that stenotic area just behind, you know,
Walk
just
it out of gypsum.
1 centimeter south of the upper edge of the bone.
Yeah.
I think calcaneum.
Yeah, get us off.
With a low pressure 5 or something like that.
50 a balloon, please.
What's happening? Almost done. Yeah. Why? How's it going?
It's just getting a little stressful there.
Why?
Okay. All right, 50 balloon, guys.
The second mass muscle, tibials.
Yep.
Yeah.
It's like not moving. She's getting.
You want to reverse him, guys?
Who's not? What's not moving? What's not moving? But what's not moving?
Enough for the stent, enough for the covered stent.
It's in there. I'm not sure. And like the.
So that's the question, Stephen, it's a trade-off, because it looked better before
Yep.
than it does now. I understand.
Can you just tell her to stop and wait for me?
Yeah, you want me to do it?
What's riskier for closing post or immediate post?
Yeah. But if it's too much, just yeah. Just tell her to stop.
I think they're still running, it's just that. I mean, you've just done a very light scaffold.
Yeah.
Just to take out the valves and the restenotic areas, you know, so. maybe PK to get a run. Maybe put a catheter down after all the post dill. Maybe put a catheter down and have a good look at the run.
Yep, absolutely. Get us a Navicross, guys. Hope slow, bro.
You follow them with Doppler every, how often?
Okay, that's
I
4.
think if you're putting in a
6,
drug-eluting stent down below, I think you're
8,
okay to
8.
run. In my opinion, the flow is fast every month, but if you're not sure,
That's 8.
then
Down.
maybe you put in once a week or twice a week. Either way, you're gonna need to follow them for wound care and stuff like that, so.
Go up here.
Okay.
TCPO2, you're following it or?
Yeah. I do it for research reasons, so
Uh-huh.
just to make sure
Down.
that.
Good, let's walk it up. And then give me some 3-5 scaffolds, guys, like I said. Up top. Corner stents, I mean. Yeah. Give me the 018 to.
PK, how about that constriction roughly at the calcaneum? Gonna bust that or?
We went up to 10.
Oh,
Yep, walk it out.
Uh-huh.
maybe a bit
What?
higher pressure around there, because it does look like a constriction there.
We're probably gonna have to go with a 6.0 balloon then. Give me a 6.0
why not?
15 Viatrack. Got it.
Want to take a picture or no?
Not yet, because I want to balloon this and then we can do the rest. Yep. There's 018 balloon, isn't it? Fuck. All right. Oh, give me the catheter then. We'll change that for an 014 wire. Give me, and then we'll use the wire track after. Give me a 014 command. We have it, I'm sure. Because we need it for the stenting anyway. So we're going to go distal here, guys, at the tip of the stent and then take a picture.
One sec.
Okay, good. Wire up. Okay. I'm going to take a picture here. Looks pretty good, Steven.
Yep.
Okay, give me the command now.
There's some going down to the toes there too, right?
So now what I'm going to do is put an 014 command, balloon it, and then stent the proximal.
So what's this other wing coming back? And you think that's the short saphenous wing in between the two?
Yeah, that's a short set coming back, but on the lateral part of the foot is back, yeah.
It's going on the lateral aspect and then post.
The anatomy looks a bit weird, but not your standard, crazy.
Nice.
Go ahead, bro. Give me the Viatrack, guys. And then give me some DS now. 3-5. Okay, can open them.
PK, I gotta.
You go, bro.
Stop by.
Yeah,
I'll
yeah.
be back.
Okay. Was everything okay in the OR? Oh shit.
I'll tell you that.
Really?
So we don't have medical.
Okay. Yep. Show me above. Right here. Right here. All right, let's go up. Yep. Okay, go up. I don't know. Is it not with dye? We got something else in there? Down? No, nothing went up.
I go to the airport. Thank you guys.
12, 14, 18, 20. Okay, down. So Stephen, I ironed that out. Go
No,
up
it's
here.
good.
Thank you.
20. Down. Okay. Over here.
Right.
Okay, just go to 12. Down. Over here. Down. I think it looks good here. Go up here one more. Down. I think we should balloon this whole thing with a 6, Stephen. But I don't want to create what happened last time. All right, so give me now a the synergies. Show me above now. 48 synergy, please. 3.5. I'm gonna need probably another stent after this. Don't open it yet. You got it? You ready? Go up. Probably need another 48, guys.
Another 3.5.
Don't open. Let me measure with this first. Go up. 12, 14, 18. Down. Up again. Down. Let's do the overlap a little. Go up now. 18. Down. Show me above. Let's measure here. Give me a little die. Inject. Okay, you don't need a 48. We just need a short one. Right? Put me on coronary, guys. I can't see anything. Mag. Okay, mag it up for me and shut her in. Shut her in. Okay, ready? Just a regular inject. So 3.5, 18, huh?
Yeah.
3.5, 18.
Does look a bit small, right?
Yeah, but it'll be fine.
Yeah, I think it'd be okay after the stent.
You're gonna take it to the ostrom, right?
I think
Yep.
you might even have to take it
Across, right?
No,
including a little bit.
not across.
I'm not sure how you can land that on the ostium directly because it's hard to see. You know, it's at the posterior part of the leg, you know, so try to find an oblique, you know, maybe that might work to help you land it.
With this guy, finding an oblique is going to be like me winning the lotto. That's fine. 20 is fine. So this one was considerably less than 3 hours, so that's pretty good. We start.
Yeah.
This one, we started at 2:30, so not bad.
I think it's good, PK. Age adjusted is fine.
Ha ha ha! Oh my God. A little die. Okay, ready? Inject. I think I'm gonna go take it. Go up.
Yep, go.
Okay, down. Go up again. Down. Go up here. Down. Go up here. Down. Okay, good. All right, we're just gonna take some final shots here. I'm gonna pull the wire back.
This is like a regular PCI. Okay.
Regular PCI.
Yeah.
All right, we're gonna give a little nitro. There's nitro.
With up and down action.
Up and down, right? That's a lot more fun than the DCBs waiting for 3 minutes. Okay, 200 of nitro in flush.
Yeah, I need some more contrast, Johnson.
Yeah, they should be designing 1 minute therapies, right?
I'm not joking. Okay, let's. All right, ready? Let's do this one first. He's moving. Let him stop moving. Hold on. Let him stop moving first. All right, ready? Inject. He's moving so much. All right, one more time. What is that? What is that in the edge here? What is that? It's underneath? Oh, there. Get rid of that shit. Okay, inject. Okay, inject hard. Inject.
Nice.
Nice.
Very nice.
Actually filling it really good.
You see some of the veins going down the foot, PK?
Yeah.
So
That's a
actually,
good sign.
yeah, can you freeze
you-
it there for us, PK? So,
You frame by frame, you can see that.
so we want to see which.
Inject.
Right, you see the PET AT veins?
Yep.
DP veins?
Yeah.
Right, those are the ones, but I think it's fine because you have to stand right, in fact, you have to stand a little bit across the bend. And, you know, I think that's good.
Thank you, sir. One more time.
Go home. Yeah.
I think it's good, man.
It looks good.
Yeah. So you guys okay with that? I think we're gonna stop with that.
Yeah, it looks perfect, PK.
PK, can you just show us the foot picture? I just want to understand the venous. Yeah, right here. Steve, you were pointing out.
Back 2 frames. Back. And stop. So you can see the PET AT veins here.
Oh, this
This is the short SAF.
Yeah.
These are the PET AT veins, so they were there actually. It's just that on previous projection you couldn't see. PK, you see that, the PET AT veins?
Very well.
Little-
Yep. But
Yeah,
they're very.
but the aim is to perfuse the arch, and your stent has just gone maybe
Whoops.
1 or 2 millimeters across the bend, but that's fine. You know what I mean?
All the way on the left-hand side was the GSV, correct?
That's a short, no, this is the short saphenous vein, the GSV is on
that
that
side, yeah.
The GSV is probably this one.
This one, okay.
Yes. Somehow it went, I don't know where it went. This one,
And on that side, on the right side
this
is
is the GSV. So if you see, PK, if you look at the most left-hand side of the vein, that's the GSV.
Yep.
And the spasm down the medial marginal vein where your wire had pulled out. So you see the GSV connects with the arch through the medial marginal vein. You see that?
It's calling you. Oh, it's
You
beautiful.
see-
I think we got a good job here.
Very nice.
So ideally, you would like to have the wire into the
AT, that's fine. As long as you want to John, you wanna see this? This is gonna pressurize and this is gonna open up.
Yep.
The first one is gonna confuse. This guy's gonna open up here. The wound's
It looks
running.
like so, no? Looks like it's pretty good. No?
Beautiful.
Yeah, it looks good, no?
All right, guys. Well, thank you again. I want to thank our nursing staff
Looks good.
who did a great job. I mean, they really managed this very difficult patient well. Thank you, ladies. And so we're going to close up here, and we'll see you guys in a few. Thank you again.
Okay, good. Good job. Good job.
Okay, take care. We'll see you soon.
Good. Yep.
Okay, bye. All right, let's get a per close, guys. We'll do a per close, and I'll have a balloon ready just in case.
You don't want to do anything to the popliteal? You want to just check?
Is there anything to the popliteal?
I don't know. I'm just saying, like, you want to just check?
Let's take a picture here. I'll pull this back. Ready? That's nothing.
Nothing. It's not bad.
I just leave that, right?
Yeah.
All right. It's already done.
Sorry, I had to step out.
Are you kidding?
The office was calling. So.
No problem, dude. What are you worried about? It's beautiful.
It looks beautiful.
Yeah.
Looks gorgeous.
Good. Tell Raj we did it. Okay. Okay. So give me a let's do a per close here. Antegrade per close.
Go for it.
Super core wire. Before doing that, I need a wire in this, and I need a balloon ready, a 6-0 balloon ready, in case I fail.
I did another supracore.
This is a 6-0 regular balloon. Why Dorado?
Regular balloon, bro. Regular balloon. 6 of 40. Yeah, 6 of 40.
Good. Okay. I gotta come on the other side.
Mm-hmm.
Oops. Yeah.